Thank you very much, Prof. Atkin, for this informative lecture. And you proceed with introduction of obesity in Bahrain, as it is a public health significant, as it is not anymore sign now, it is a disease. You told us about the definition and the classification, and it is more in sub-Saharan Africa, Central Asia, and Middle East. Health effects, lots of health effects, multifactorial and life expectancy as BMI increase, the globally death associated with BMI increases as well, and comorbidity as well. Thank you very much for this informative lecture. Let us move to second lecture. This is medical management of obesity for Dr. Sara Suliman. Dr. Sara Suliman, she is a consultant diabetologist and endocrinologist, bariatric physician, and clinical lead for the genetics of diabetes and endocrinology, Imperial College London, Diabetes Central Abu Dhabi, UAE. Honorary Senior Lecturer, Imperial College, University London. Please welcome with me Dr. Sara Suliman from United Arab Emirates. Dr. Sara, the floor is yours.
I'd like to speak with you about medical management of obesity. I have no disclosures, I should say. And just to give a little bit of background to this talk, what are the benefits of weight loss? Even small amounts of weight loss have quite large effects from a metabolic point of view. So even less than 10% weight loss, if we look at the left side, can result in increased liver sensitivity, insulin sensitivity, improved beta cell function, skeletal muscle insulin sensitivity, and adipose tissue insulin sensitivity. What does that translate into? Even a weight loss of less than 5% can improve hypertension and hyperglycemia. Between 5 and 10% can prevent type 2 diabetes in those prone to get it, can improve non-alcoholic fatty liver disease, can improve polycystic ovaries and dyslipidemia. If we look on the right side with a weight loss of over 10%, this results in reduced intrahepatic triglyceride content, reduced visceral obesity, and vastly improved adipose tissue biology. And as a result, people who lose more than 10% of their weight can have improvement in cardiovascular disease risk, NASH or steatohepatitis, sleep apnea, osteoarthritis, GERD, esophageal reflux, and stress incontinence, and basically the bottom three all being mechanical issues related to obesity. In those who lose more than 15% of their weight, this can result in type 2 diabetes remission, reduction in cardiovascular mortality, and improvement in heart failure. So if we follow the guidelines, who would we be treating, either medically or surgically as necessary? The NIH guidelines suggest that medical treatment is appropriate for anybody with a BMI of over 30 kilograms per meter squared, or those with a BMI of over 27 kilograms per meter squared, plus 2 risk factors of diabetes, type 2 diabetes, hypertension, hyperlipidemia, ischemic heart disease, sleep apnea, providing that they have failed to lose weight on lifestyle changes for 6 months. We certainly do not treat that number, and I don't think we would have the capacity. However, it's important to know that. Historically, medical management of obesity has been extremely poor. So most of the drugs that were discovered before 1999 have actually been cancelled, including ones which resulted in sudden death, valvular damage, hypertension and stroke, rimonabant with psychiatric disorders, sibutramine with heart attacks and strokes. However, since then, there has been a plethora of medications that are currently available that appear so far to be safe, although we'll speak about their side effects. So in 1999, Xenical was discovered And most recently, last year, semaglutide 2.4 milligrams, or Wegovy, was FDA approved. We'll start with orlistat. It's a pancreatic lipase inhibitor. It malabsorbs 30% of ingested fats, results on average in 2 to 3 kilogram weight loss. It has limited success in losing significant body weight. Orlistat is a pancreatic lipase inhibitor. It malabsorbs about 30% of ingested triglycerides and removes them in stool. Can result in a 2 to 3 kilogram weight loss. It has limited success in people losing more than 5% of their body weight, although some individuals do actually benefit from it. It's used with each meal. It's relatively safe, main side effects being diarrhea or oily stools and spotting. It can cause fecal urgency or incontinence. It's available in most countries, and in some countries is available over the counter as Ali. The weight loss, we've said, is quite modest. There's about a 2 to 3 kilogram weight loss between that and the lifestyle group. The next one, Cusmia, is a combination of phentermine and topramate, phentermine being a noradrenergic appetite suppressant, and topiramate is a neurostabilizer used for migraines and epilepsy and can result in quite significant weight loss. This is licensed for long-term treatment. It has a weight loss average of about 6 to 11%. About 70% of people achieve the 5% weight loss, and about 48% of people achieve 10% weight loss with the associated benefits. So this is just a graphical representation of the 7.5 milligram dose and the 3.75 and the 7.5 milligram dose compared to the 15 milligram dose. With the 15 milligram dose, there is loss of about 15% and less so with the smaller doses. The side effects mainly relate to topramate. The protocol is of gradually increasing dose, starting with the 3.75 for 2 weeks, onto the 7.5 for 2 weeks. If there is a more than 3% weight loss, you continue treatment, and if not, you increase the treatment to 11.25 and then finally to 15. After achieving the 15 milligrams, if less than 5% weight loss is achieved in 3 months, then it is unsuccessful and treatment should be stopped. The main risks are in people with renal impairment or hepatic impairment. You should not use higher doses, can affect mood and sleep, and can cause cognitive impairment. In people prone to glaucoma, we would avoid using it. All medication for weight loss should be avoided in pregnancy. Also should be avoided in people with suicidal thoughts or previous suicide. The main side effects are headaches, dizziness, and paresthesia. Can increase heart rate, and in people who have recent unstable cardiac disease or are thyrotoxic, it should not be used. Can also result in metabolic acidosis, which often resolves spontaneously, and can result in an increase in creatinine and hypokalemia. The next medication, lorcaserin or Belvic, is a selective 2C receptor serotonin agonist. It activates the satiety pathway, and about half people who use it can have more than 5% weight loss. It's a lifelong treatment, and dosage is 10 milligrams twice a day. Similar to most anti-obesity medications, if weight loss is not achieved after 12 weeks, the treatment should be discontinued as unsuccessful. On average, people lose about 5.8 kilograms. The main side effects are related to serotonin itself. It should be avoided in pregnancy, can adversely affect memory and attention, and headaches, dizziness, fatigue, nausea, the serotonin syndrome can be quite prominent in some patients. The next medication is Contrave, which is an extended release combination of naltrexone, which is used to treat drug and alcohol dependence, and bupropion, which is used to use nicotine addiction, commonly known as Syban. The mean weight loss is about 4%, and there is a significant dropout of about 40% in both placebo and treatment groups, but between them, there is a loss of 9% of body weight in the treatment group compared to 5%. The dosing is interesting. For the first week, they take 1 tablet. They then gradually increase to 2, 3, and 4 tablets. And after 12 weeks of being on full dose, if the weight loss is less than 5%, then the treatment should be discontinued. The main risks are GI side effects, headaches, dizziness, insomnia, again, risk of suicidal thoughts and behaviors. Serious neuropsychiatric events have been reported. Try and avoid in people with high blood pressure, seizures, glaucoma, renal failure, and pregnancy. GLP-1 agonists have become the mainstay of obesity treatment in recent years. Liraglutide has been around since 2006. This GLP-1 agonist, it's centrally acting with some peripheral effects. It's an appetite suppressant, but also reduces gut motility. The mean weight loss is about 8%, with over half of people achieving 5% weight loss and almost a third achieving 10% weight loss. The dosage is gradually increased, starting at 0.6 and then weekly increments of 0.6 until the maximum dose of 3 milligrams is achieved. So this is one of the original scale studies looking at weight loss with liraglutide, and if you look at the bar chart showing increasing doses with the effect on weight loss, and at the highest dose of 3 milligrams, there's a weight loss of about 8 kilograms. Looking at patients with diabetes who often have less weight loss, again on the scale studies, it's reasonably significant, with the highest dose resulting in about a 6.4 kilogram weight loss. Looking at maintenance of weight after weight loss, so liraglutide not only helps people lose weight, but once they have lost the weight, it is helpful to continue with therapy. Once this therapy is released, there is a little bit of a drift, as we can see on the right side of the graph. However, there's still a significant difference between those who were treated with lifestyle alone and those who were maintained on liraglutide. So in summary, for the scale studies, about 3/4 of patients, 76%, managed to lose more than 5%, and about 30% managed to lose more than 10%. There are hyper responders, and there are those who do not respond at all. The side effects are mainly gut side effects. There were huge rumors about medullary thyroid cancer. However, this appears to not be the case in humans. We do try and avoid it in patients with a family history of medullary thyroid cancer or MEN2. There's a low risk of pancreatitis. However, we do warn patients about it, and particularly in those who lose weight quickly, there is a risk of gallstones and cholecystitis. It can result in tachycardia and renal dysfunction, particularly in people who do not drink sufficient water. More recently, semaglutide, a long-acting GLP-1 agonist, has been licensed for obesity management, and the weight loss with semaglutide 2.4 milligrams is approaching what we would see with bariatric surgery, so 16.2% weight reduction at 68 weeks. It's more modest in people with diabetes, with the 1 milligram dose resulting in a 6.2% weight loss, and the 2.4 milligram resulting in almost 10% weight loss, compared to 3.4% in people treated with lifestyle alone. Oral semaglutide has recently come into the market, and it is licensed for treatment of diabetes. It's the so increasing doses in blue, ranging from the light blue to the 14 milligrams as the dark blue, and compared to empagliflozin and even Victoza, there is a significant reduction in HbA1c and in weight with a higher dose of oral semaglutide. There are newer agents, which at the moment are for named patient basis, including cagrilintide for weight management, which is homologous to human amylin. It has a long half-life of about 180 hours, so it's given once a week, and increasing doses result in a reduction of up to 11% of body weight, so more powerful than liraglutide. And in combination with semaglutide, this results in a significant reduction, with 2/3 of patients achieving more than 15% weight loss. Again, we're talking about bariatric surgery territory here. Another new drug, tirzepatide, which is a combination of GLP-1 and GIP agonist, has shown significant weight loss, up to 11%, with gradually increasing doses. A very specific medication, which is for people who have genetic causes of obesity, is setmelanotide. It's an MC4 receptor agonist. It was developed initially for people with leptin receptor mutations or POMC mutations, but actually, as I'll show you, many of the mutations that cause monogenic obesity are along that pathway, and there is a prime designation or granted priority medicines designation to try and give it to these people. So in a healthy individual, there's a combination of a hunger center and a satiety center, and the MC4 receptor balances the signals coming from them. In people with genetic obesity, there is loss of the signal from the satiety center, which results in increased hunger, and treatment with setmelanotide tends to improve that. So POMC and the MC4 receptors are the center, if you like, of monogenic causes of obesity. Leptin receptor are upstream of that and positively regulate POMC, whereas other mutations are downstream of that. And again, trial of setmelanotide in these individuals is probably helpful. I'd finally like to speak about what is actually approved by the FDA as a medical device, but is really a medication as it comes in tablet form. It is a tablet which has jelly inside it that absorbs water and fills the stomach, so it's a mechanical effect. It can be used to induce satiety or fullness, has no apparent side effects, and can be used safely with other medication. In a randomized double-blind placebo-controlled study, there was a 6.4% weight loss at 24 weeks. However, in about a quarter of people, they were hyper-responders with about 10% weight loss. There are anti-diabetic medications that cause weight loss, SGLT2s being the most obvious of them, apart from GLP-1 agonists, of course, and metformin in about 10% of people can cause significant weight loss. I don't need to tell you about SGLT2 inhibitors. They prevent the reabsorption of glucose from the nephron, and they result in about 2 to 4 kilograms weight loss at 2 years. However, again, there are hyper responders who can lose significantly more weight. Should we consider combinations for obesity? Well, we look at diabetes, for example, and there is a clear pathway to adding medications or using combinations. This is even clearer in the older ADA guidelines, showing us which medications to use in combination. If we look at hypertension, similarly, There are clear guidelines on what combinations to use and when to titrate up. Unfortunately, with obesity, we have not been doing that so far, but it might be a sensible course. We've spoken about a few options and the weight loss associated with them. Some of them can interact, but for example, a GLP-1 agonist and an SGLT2 inhibitor in diabetes is a very reasonable choice, or orlistat in someone with a high-fat diet with an SGLT2 inhibitor. One of the limitations is cost. And if you look at them, so certainly in the UAE, medication for obesity is not funded, and it can cost significant sums. So for semaglutide, which is currently the most, the best obesity medication, if you look at weight loss, then this can be up to about 1,200 Emirati dirhams per month. So in summary, there are good therapeutic options for obesity which are available. Each drug alone may not be ideal or may not fulfill the whole weight loss that is required. However, combination therapy and newer medications coming through are very interesting. There are always going to be hyper responders and people who do not respond very well. And what we've shown you today is the average for people rather than both ends. Maybe the way forward is going to be pharmacogenetics, where we can use DNA profiling using a chip to find out who will respond really well, who will not respond, who might get side effects. And accordingly, rather than treating everyone the same, we would then treat people who respond on average with a pill, people who are less responsive with 2, people who get side effects we would not treat. So in conclusion, the medical treatment of obesity has been an abject failure. However, we're now spoilt for choice. There are a few medications licensed, and there are a few more in the pipeline which show promising results. Some can result in significant weight loss, particularly in certain subgroups, and some have a role in the management of diabetes. Long-term safety is still to be seen, but some of them are about 20 years old and going strong. Combination therapies and pharmacogenetics may have added benefit. Thank you.